Good afternoon, everyone. My name is Sheronda Wilson, and today I'm presenting my capstone project titled Healthcare Intelligence, Risk Utilization, and Quality Analysis of U.S. Nursing Care Facilities. This capstone develops a healthcare intelligence system utilizing publicly available Medicare data queried through Google BigQuery, along with machine learning and explainable AI to better understand why some healthcare facilities generate higher cost, higher risk, and different utilization patterns than others. Facility level features were engineered from the CMS data sets containing utilization payments, demographic, and clinical complexity indicators. My goal was to move beyond traditional descriptive reporting and build a more intelligent, scalable decision support framework for healthcare analytics. I will briefly walk you through the innovative pipeline, the background, dimensions of performance, the methodology, explainable AI, research objectives and significance, the results, limitations, conclusions, and future directions. So a lot of people do not understand what is Medicare. So I want to give you a little background of Medicare. Medicare is a federally funded program that provides health insurance to individuals that are 65 and older, anyone receiving Social Security disability insurance, or anyone that's 65, under 65 and have kidney disease, where they require maybe dialysis or a possible transplant. Medicare have no income requirements. There's two different Medicare benefit options right now, the traditional Medicare, where that's federally funded through the government, and then there's Medicare Advantage, where there's now offered private plans to be contracted through the federal government. Well, what is BigQuery? Google BigQuery is a cloud-based analytics platform designed to process very large data sets quickly using SQL. For this capstone, I used the public CMS Medicare data set, which also includes that Medicare provider claims, which was about over billions of provider claims. And my data set was broken down to maybe about 15,000 provider claim information that provided payments, utilization, and facility level information. One major advantage of BigQuery is that it removes local computing constraints. And instead of downloading large files to a laptop or your technology device, I was able to query millions of records directly into the cloud and bring only the necessary results into the Google Colab or the Python for modeling and visualization. So the pressure mix. Healthcare systems face increasing financial and operational pressures, especially in long-term care and nursing care facilities. Not all facilities perform the same. Some have higher costs, longer stays, and greater patient complexity. Traditionally, reporting relies on retrospective descriptive statistics, which makes some facilities appear more efficient. While skilled nursing care facilities manage some of the most complex populations, presenting as the primary reason of high Medicare costs and primary quality of care. Many healthcare leaders often ask two questions. Which facilities are driving higher Medicare spending, and why are these differences happening? This project was designed to answer both questions using the data science methods. Rather than only identifying expensive facilities, I aim to uncover the underlying drivers of the variation. My core hypothesis is facility level characteristics, especially focusing in on patient complexity, their length of stay, and utilization intensity, significantly influencing the Medicare cost outcomes and can be used to predict higher cost facility profiles. This hypothesis is supported by prior healthcare literature, such as that show risk burden influences of reimbursement, longer stays that increases in spending. Administrative claims data can be used to predict the modeling, and explainable AI can improve trust and transparency in healthcare decisions. This capstones extend that work by integrating descriptive analytics, predictive modeling, clustering, and chat into one pipeline. So this pipeline, the data set used in this study was derived from that publicly Medicare provider data set. It contains facility level records for U.S. nursing care providers and includes variables related to the patient risk burden, utilization reimbursement, and the geography and where their demographics are. So in this pipeline, the raw data was cleaned where missing values was handled. I also identified the outliers, the cost per beneficiary, transformed the skewed data. Then I selected the key predictors. And this data set was split into trained test subsets using an 80-20 split. And so now this model was ready for analysis and modeling. So I used the 5-stage analytic engine. And so with descriptive analytics, it helped me to understand the data before modeling. So I used the charts and summaries to compare and identify patterns that's in the cost and the utilization and the risk scores at the state level and figuring out the variations across the nursing facilities. So my question here was, what happened? In the comparative intelligence area, that means I compared the facilities in the states and grouped them to understand who performed differently and why. This helped turn the raw numbers into actionable benchmarks and disparities, and gave me some insight on the disparities. In the predictive modeling area, I use supervised machine learning to classify the high cost facilities. Predicting modeling does not prove causation. It just helped me to identify those models. And so in that area, the question that I had there was, what is likely to happen? In the segmentation area, I use unsupervised learning to identify facility archetypes. And this also helped me to discover the hidden groups in those Medicare payments. And so on the last area, I use SHAP to further explain those driving predictors. As mentioned earlier, I also use that cloud native pipeline. So the data ingest, if I source that massive 2020, 13, 2014 data set, they did not currently have all of the information for 2024 forward just yet for enough states, because this data set is of course, given by people, the facilities self-reporting their information. So the computational environment was, of course, the Python analytics and visualizations and modeling. My feature engineering, those variables were created and I focused in on cost per beneficiary, the claims per beneficiary, the utilization ratios, and my average HCC scores. The combination of these, the Python, the SQL, and the cloud computing reflects a more modern versus traditional view of this data set. So one of the first findings was that the payment variables were extremely right skewed. This means that most facilities had moderate costs while a smaller number had exceptionally high payments. This is common in healthcare spending data, where a minority of the providers account for a disproportionate share of the expenditures, because there is no one set way of reporting these expenditures. Because the data was right skewed, I had to apply log transformations to handle all of the zero values. So then I was able to get the true central distribution more clearly. So this is the geographic analysis, and it shows a strong regional variation in healthcare utilization and cost intensity. Some states had more facilities, more beneficiaries, and higher aggregate payments. If you notice here, Texas and Florida had a high amount of agencies that had a high cost per beneficiary use. And out of all of the 10 top agencies, Texas had 6 of those 10 agencies, and Florida had the remaining. This suggests that there should be a demand for policy review in these particular areas. I also found that the facilities with the higher use scores generally had longer average stays, greater claims in volumes, higher drug costs, and increased Medicare payments. If you notice here, the larger the block and the longer the whisker shows, the higher HCC payments. And if you notice, Texas again in this area kind of stands out and supersedes all of the other states. So this suggests that both geography and patient complexity play important roles in spending patterns when it comes to Medicare payments. To make the findings more tangible, extreme examples, I wanted to look at, well, what's the difference between the highest and the lowest? And so if you noticed here, I found that there was a really high amount in the state of Texas where they were charging per beneficiary $21,337 as compared to the lowest, which was $1,755. And so as you notice there is a $19,000 discrepancy. So this demonstrates that the high Medicare spending is not always driven by large patient volumes. In some cases, it's driven by very high per patient intensity. So in this slide, I created a binary target variable to classify the facilities that was in the top 25% of Medicare payments, which represented the high cost facilities. So this table shows those 10 agencies that had the highest average cost per beneficiary. This gives us a quantitative measure of performance in terms of cost efficiency per individual served. And so when you look at this graph, the deeper the red color, the higher the cost, which means that these agencies have the highest average Medicare payments per user. A high cost per beneficiary can indicate a few things. They might be treating more complex cases that require more extensive services, leading to higher payments. They could also be less efficient in their service delivery, which resulted in higher costs per individual served, or they might have a patient population that just requires more care. It's important to note here that if you're looking at highest or low here, costs don't necessarily equate the best or the worst quality of care. You would have to do further investigation into the patient outcomes, the case mix adjustments, and service quality metrics. This metric primarily highlights differences in resource utilizations or payment complexity per individual served. Next one. So here I also compared several models, logistic regression, random forest, and XGBoost. The best performance model was XGBoost, which performed well because it captured nonlinear relationships and interactions between the variables. The XGBoost model achieved excellent discrimination with the ROC AUC at 90% and an overall accuracy at 80%. Performance was strongest for the majority class with the near perfect recall for the class 0. For the highest cost class, that model achieved exceptionally high precision at 99%, indicating that the flagged facilities were almost always true positive. However, the recall for class 1 was only at 48%, suggesting that substantial proportions of the true high cost facilities were not identified. This indicates a conservative classification threshold favoring precision over sensitivity. So this means that factors such as the risk burden, the utilization, and the cost intensity they don't behave in like a simple linear way. So the predictive modeling result supports the hypothesis that high cost facilities can be identified using measurable operational and clinical features. I also took it a step further with using SHAP to explain the model decisions. So SHAP showed the strongest drivers of predictions, and it included the distinct users receiving the care, the non-LUPA care is what is categorized, the cost per beneficiary, average cost, and claims per beneficiaries. This is important because the machine learning alone tells us what may happen, but this SHAP tells us kind of why it's happening. For example, the high patient volume increased predicted cost risk, and the high cost per beneficiary increased the risk, and the higher HCC scores reflected more medically complex population. Also with the K clustering, the means cluster, K-means clustering, it identified 4 distinct facility archetypes. And so the first cluster basically handled a large amount of the episodes, the payments, and the beneficiaries, resulting in higher overall charges. In cluster 1, importantly, this cluster had most complete demographic and health conditions, like they had a high percentage of beneficiaries with hypertension and hyperlipidemia, suggesting they manage a diverse patient population. So in cluster 2, the smaller agencies with the lower activities had some reporting gaps, meaning that they did not have like a set model where the metrics were prevalent, or they had to use a set model to report their Medicare payments. And that also, this cluster also kind of showed issues with their Medicare payments came from most of their outlier adjustments. And cluster 3 was just like 2, except that all of their payments were driven by their outlier adjustments. So there were several limitations in this. This was an observational study using claims-based administrative data. Again, those administrators had to upload their information into a system and self-report this information. Some variables were missing. They may be missing or underreported because there is no set structure for Medicare right now to report these things. Zip codes were kind of limited in some areas. Clustering results depended on pre-processing choices and not the absolute truth, right? And so high predictive performance does not necessarily equal direct measurements for this quality. In conclusion, this capstone transformed healthcare reporting into a dynamic and explainable analytic system. The framework identified which facilities generate higher costs, which serve higher risk populations, how the utilization differed, and why the predictors occurred. As future directions, I'll add in 2024 through 2025 as it becomes more information becomes available. I would also like to include readmissions in the study, building a interactive dashboard, and also expanding on explaining fairness and equity by race and gender. Overall, this project demonstrated how biomedical data science can support smarter healthcare decisions, because making decisions and using data is important. So that's my references. And I would like to thank my advisor, Dr. Pinky, for working with me to produce this capstone, and Meharry Medical College professors for preparing me. Any questions?
Thanks, Sheronda.
I'm sorry, I did not turn on my camera.
Oh.
Thank you for turning it on.
I had a question, Sheronda. I think, like I said, the presentation was excellent. I just wanted to ask you, I know Medicare, one thing I think about with that is Medicare fraud. Is that something that you're trying to factor into your work, or is that something that you considered when you were doing this?
Yes, so with the expansion of doing deeper learning, or getting more deeper learning models, I would like to factor in some of those frauds. But until right now, the Medicare system is self-reporting, and so until all of that data and the overhaul really happens, then you really may not ever get down to Medicare fraud, and it's kind of like going to be what they call searching for straws, grasping for straws. But yeah, this is I would love to continue in this research, as Medicare is a system that's, pulling trillions of dollars from the federal government. So